Right, we'll make a start for those that are not sitting down. No. Oh, protect me from the draft. Yes.
Mark Whiteman was just saying that they've got Secretary of State and CQC in at the moment, so he won't stay once the discharge.
What's that bit? Yeah. Okay, we'll let him go. Okay. Right. Okay. So welcome today to the our Leicestershire County Health Overview and Scrutiny Committee. I'd like to remind everyone present that this is broadcast live, and you can see what's happening on the screen over there. The next thing is to say turn your phones off, which I didn't yesterday. That's through the County Council's website, and it's going to be available therefore for people not just during the meeting if they want to watch it, but also after the meeting. Everyone remember to turn their microphone on, which I'm not very good at, when speaking, and then off when you've stopped speaking. Minutes of the meeting were held on the 5th of June. What do people think about those? Are people okay with those that were here? You had a point to make, but were you okay with what we said this morning about the PCNs?
Yeah, I think it was just to see whether or not we could get any clarity on the item 12.I about the 26 posts that have been advertised and the 13 new members of staff, just to clarify that's per PCN. That's hope. Thank you.
Was the key point. It was, yes, it could be read either way.
Thank you.
So everyone's happy with that. I signed those. Thank you very much. Question time. I've not received any questions from the public. Questions asked by members understanding orders 7.3 and 7.5. I've not received any questions. Not been advised of any other items to be taken urgently. Declarations of interest. Anybody got any interest they want to declare? Nope. Thank you. Declarations of party whip. Any whips being set today? Declarations? No. I've also not received any petitions under Standing Order 36. So we can now get on to the first item of the agenda point of view, which is a report by Healthwatch, their annual report, agenda item 8 on page 11. And I imagine, Michael, that you're going to take us through this, aren't you?
Thank you, Chair. I suppose there's not really much to add to the actual report itself. It's just a bit of a kind of a précis of what we're up to last year, and just to kind of set the bit of context that was the first year where the Healthwatch contract in Leicester and Leicestershire was jointly commissioned. So I myself kind of moved over from the Healthwatch contract that was delivered in Leicester City. It was taken over by an organisation called Engaging Communities Staffordshire. So there was an element of kind of setting up and trying to kind of re-establish the some of the structures, the volunteer board that we run, that's the advisory board that sets a lot of our strategic priorities and kind of oversees our progress locally. So it's something that we're required to do as the local authority is, and most of the NHS organisations, to have these annual accounts about what we've been up to and how we've been trying to deliver our own remit. So it's very much a case of kind of opening it to any questions, really.
So, anybody got any questions or comments about the annual report that Michael's just introduced? Yeah, go on then.
No, I think I just wanted to say that I love the crystal clear presentation of it, and the message and the case studies, really, and it's good for an easy read for members of the public, which that it's meant to be. So it does what it says on the tin, basically. My only thing I would say is, if we could extend the sampling so we can get a bit more far-reaching idea of what's happening in a bit more depth on the sampling, that would be great. But yeah, really pleased with it. Thank you.
Thank you, Councillor. And I think, is that more connected to the discharge report rather than the annual report, would you say?
No, I think in general, I mean, when I looked at the numbers of the people you were reaching, it would be just good if we could, double that sort of thing, so we got a better feel for what was actually happening.
No, you're absolutely right, and I think one of the realities is that was for about a good 6 months of the first year. It was about kind of trying to re-establish a lot of the structures that had unfortunately been lost as we moved away from the separate Leicester and Leicestershire structures, and had to re-establish a lot of the things that were unfortunately lost because of various reasons, if you will. But absolutely, the target is to be engaging with a lot more members of the public, capturing a lot more experiences. And we've just been running a very successful summer engagement programme, going out to a lot of festivals and events around Leicester and Leicestershire. So I know for a fact that we're already at least double, if not triple, that number. So, yeah.
Yeah, Terry.
I think my point was stressed similar to Maggie's. I mean, what do we believe the optimum number of people is we should be engaging? So it says on page 16, 483. Now, just in budget terms, that works out at 600 quid per person we've spoken to, which seems quite a lot of money. I just wonder what you believe is the optimum number of people we should be talking to, and the optimum number of people we should be helping. So I think later in the report it talks about 195 people we've signposted, which doesn't seem a lot.
I think it's quite a difficult answer to give in a sense of having any kind of set amount. I think that one of the targets that I know that we want to try to work towards is roughly, I think if we had everything we wanted to, I think if we were able to say that we'd engage with about 10% of the population kind of over a year. And as far as the kind of number of people that we've been able to help with signposting or through various different avenues, again, that's, I think, very much a case of as long as we're engaging with that number of people, whoever then come back and we can offer. But yeah, it's very much kind of limited to the resources.
Yeah, Mike.
Yeah, for me, just to sort of clarify that question, because I guess it depends on your methodology, doesn't it? It's whether Healthwatch goes down a sample of respondents and what size sample you need to make it valid, or whether you try a different methodology, which is more along the lines of a Delphi technique, which is you keep on asking people until they're telling you the same thing. So I suppose to try and unpack it a bit, there's an element of me of, is there any set kind of methodology that Healthwatch needs to follow nationally, or is it mix and match?
Short answer, no. There's no set framework around it. And some of the different projects that we do, we would engage different techniques depending on the question we're asking. So if for example, we're just coming to the close of a piece of work around medicines management and the different experience for patients between hospital and primary care. And that is very much, it's a survey. We can kind of send that out. We can kind of use that and go to a number of different either public events or specific community groups. Whereas if we're asking a question very specifically around a specific condition, then it would be kind of an interview kind of technique. So it'd be quantitative versus the qualitative. So you're looking for the rich detail rather than the numbers. And it's a lot of the research projects that we do, the initial proposals are pulled together by a colleague of mine who's based within the head office of ECS, who's a kind of in charge of the research methodology. So would kind of should pull together a proposal that then be reviewed by the advisory boards to make sure they're happy with how we're going to go forward with that. So yeah, just about making sure that we're trying to use the best methodology, considering what we're trying to achieve, who we're trying to target, and ultimately what we want to kind of gather as far as an insight.
Okay. The only point I was going to raise actually was public views of access to GPs in Leicester and Leicestershire, page 23. I see it says the July to September, which is a year ago, isn't it? And I mean, I've got a situation in my area where two of the GP surgeries just merged. And my view, and it is only mine and not anyone else's, is that it's now much more difficult to get appointments. You'd think it'd be easier because there's now more of them, but it seems a bit hard. I just wonder whether, next time we run it, perhaps in a year or so, it'd be interesting to see if the figures you had from a year or so ago has actually changed the trend. That's all.
It's Kibworth, isn't it? Yeah, and I think the reality is that over the number of years that I've been around with Healthwatch and the local involvement networks as the precursor version of this, Kind of GP services has always been quite high on the agenda, and access to appointments, communication within the services themselves has always been something that comes out quite strongly. One of the points that I recently made at another scrutiny meeting, when there was a question asked around how do you know if the primary care networks are starting to work, and my response was people can get appointments will probably be a good indicator, and just kind of see whether or not that is starting to kind of improve patients' access to services, given that that's fundamentally what that's going to be one of the drivers. So yeah, I'll certainly kind of take that back.
Into the primary care network and the outcomes. Yeah, that's a good idea. Okay, looks like you're let off lightly there then. Thank you very much, Michael. No, it was a good report. My general report, but discussion with people in the last couple of days has been, it's great to see examples and obviously a bit more details about how it's going now that Leicester and Leicestershire come together. So yeah. The next. Oh, Amanda. Sorry, Amanda.
Just on the page 28, you talk about the library drop-ins Leicester City. Are there plans to replicate what's gone in the city with the county libraries?
Thank you. No, absolutely, and that was something that kind of has been already happening this year, that whenever there's a conversation on what we're doing in the city, given that we're now a Leicester and Leicestershire kind of organisation, that it's always going to be one of the first expectations. And we'd also hope to try to engage with the parish councils as well within the county. However, that was a lot more hit and miss.
Light. Oh, how wonderful. Okay. Yes. Anyway, that we finally got light on it. Thanks very much. Okay, let's move on to agenda item 9 then. Again, it's Michael and Health Watch, but this is a specific bit of work reporting on hospital discharge report. Mark, yes, please. Come to the table. Those of you who don't know, this is Mark Whiteman. He's the Communications Director. I think you've got your title, isn't it? Yes, there you go, from UHL. Yep. Correct. But although it's a Health Watch report, because it's clearly a lot of it involves hospital discharge, Mark's very kindly decided to come along and he may be able to give us a few clues of what's going on.
Thank you. So this was something that we wanted to do, kind of, and as with most of the work that we undertake, it's off the back of what members of the public and patients have been sharing with us, as well as some of the conversations we're a party to, given that we sit in a lot of STP meetings, the Sustainability Transformation Plan meetings, that's looking at how the services of health and social care are kind of coming together and going to be delivered going forward. It was also something that we had a hope that would be done and replicated across different Health Watch contracts within the Engaging Community Staffordshire portfolio, as it's now responsible for 8 quite Health Watch contracts, I believe. So again, what we wanted for this particular piece of work, it was very much about trying to speak to people at length and have a conversation around what their experience was. And I think whilst the numbers are low, we would have hoped to get a higher sample of patients. I think it is interesting that it's kind of really emphasises issues that we had heard about, and I would be very surprised if any of this is new to Mark, given some of the conversations that we've had. But I think it's definitely worth making sure that the committee is aware about how involved Mark and colleagues have been to help us kind of get this set up, to get in front of the right patients, and the conversations that we've had since the initial findings kind of came to light, and some of the kind of secondary issues that we've had identified. So kind of speaking to people whilst they were in the discharge lounges, so as they were almost about to kind of leave the hospital services, what we had hoped to be able to do is then talk to patients a couple of weeks after they'd been discharged. Unfortunately, it was very much we left it to the patients to say, is this something that you'd be happy for us to do? And unfortunately, we didn't really get much take up on it. So it's just something we'd hoped to achieve but weren't able to really kind of take forward. So with regards to, as kind of suppose the highlights, if you will, It just adds a little bit more kind of evidence to the kind of reality of patient's experience being discharged. So identifying issues about actually being a part of that discharge planning, and wanting to make sure that it's a discussion that's happening between the patient and the hospital services, rather than it just kind of being a sense and I'd say only a sense of kind of being pushed out the door. The other issue, another issue that was identified was regards to the actual length of time that patients found themselves within the discharge lounge itself. And there's an understanding that the hospital wards want to try to kind of clear the space so they can bring more patients in, and the discharge lounge offers a kind of a temporary measure, but it's then the length of time that patients are finding themselves there for various issues, whether it be prescriptions or whether it's actually kind of services being arranged kind of to allow them to then be fully discharged. And that then kind of leads me on to the kind of final highlight with regards to things kind of being changed at the last minute, and just not really having that conversation with the patient when they change, and understanding that the hospital services are a very kind of fast-pacing kind of environment where things can change at last minute, but just wanted to make sure that there's a kind of a meaningful discussion with patients and their families kind of during that process, so they know what's coming, and it's that kind of setting the expectations for patients, which is, to be honest with you, probably one of the most common thing I say to social care colleagues as well as health colleagues across the piece. So it's not a common to just this process or just this kind of service. The one thing that I did just kind of want to say is that as far as the kind of next steps with regards to this, we set the whole the actual project up in a lot of conversation with Jill Statten and Alison Taylor, who are kind of probably the best people within UHL to talk to as far as discharge and the discharge process. And that kind of conversation is kind of ongoing as far as, okay, what's this identified? How can this be taken forward within UHL? So the conversation as to what we're going to now do with what has been highlighted is already kind of in process and already progressing. So, I'll kind of open it up to any questions, unless Mark's got anything he wanted to add.
Did you want an immediate response, or do you want to wait for some questions, comments?
I have things to say in response, but would it be better left until the questions, or do you want me to? I really don't mind either.
I think I should get.
Okay. Fine. Okay. I think you probably will, actually. So, first thing to say, for those of you who don't know, Healthwatch and Leicester's hospitals work really quite closely together. So, we invest quite a lot of time in the relationship with Healthwatch. They are, if you like, first among equals in terms of our stakeholders, because they have a statutory duty as well as a kind of an interest. I think personally that pays off, because holding up a hospital and the way we work through a slightly different lens is always useful. So this kind of feedback is always useful, even if sometimes or often it's quite hard to hear. I was intending bringing one of the people that Michael referenced, Jill Staten, along with me today. She's one of our matrons who is leading on discharge. Unfortunately, today's been quite an extraordinary day in the life of Leicester's hospitals, because the CQC arrived this morning for an unannounced inspection, and the Secretary of State arrived 20 minutes ago for almost an announced visit. So, yes. I need to set a bit of context around discharge. So, Michael and his team talked to 18 patients who went through the discharge lounge at the Leicester Royal Infirmary. Broadly, every day, just in terms of adult patients, we'll discharge somewhere in the region of between 180 and 300 patients a day. Only about 5 to 10%, depending on the day of the week, will go through the discharge lounge, and the rest of them are discharged straight from the wards, which actually is the way it should be. And Michael's right when he says, in one sense, the discharge lounge is kind of a waiting area before you are discharged. I'm going to come back to that idea of waiting in a minute. The criteria for patients going to the discharge lounge is that they're waiting for collection by relatives, they're waiting for hospital transport, they might be waiting for what we call TTOs, but essentially it's just take-home medicines, or they're waiting for transfer to residential or nursing homes. So the key adjective in that is that they are waiting for something. And actually, I should have spotted this, Michael. I owe you and your colleagues an apology that when we were doing the sampling for this, I think we should perhaps have said, do discharge lounge and wards to give a more balanced picture. No, that's not right. It doesn't mean this picture isn't balanced. This is absolutely the right picture for people who go via the discharge lounge, but it isn't. It can't be extrapolated again across all patients, I think is what I'm saying. So that being the context, are we as good as we need to be in terms of discharge? No, I don't think we are. And actually, it risks, if we don't do something about it, becoming worse. And this is not just a UHL issue, this is an NHS issue. And the reason I say that is that discharges are becoming increasingly more complex because patients are becoming increasingly more complex. They are frailer, they have higher acuity, they have more long-term conditions, and they have more needs, and therefore they're not quite as easy to get out of the door as they were 10 years ago. So we've got to be able to do it better, otherwise patient experience of discharge is going to become worse. We're intent on doing it better. Some of you might have been at the Joint Health Overview and Scrutiny Committee yesterday. Is that all right? And you'll have probably heard my boss, John Adler, talk about the quality strategy, and one of the key strands of the quality strategy is improved discharge processes. To be honest, we're doing that for two reasons. First reason is that actually, experientially, patients deserve a better service from us on discharge. And when I say us, it's not just the hospitals, it's the ambulance service, the transport service, social care sometimes, nursing homes. But they deserve better. Second reason is, to be absolutely frank, and I don't know whether John covered this or not, we need to create more capacity in Leicester's hospitals. In other words, more beds. We can't just build more beds, as in build more wards, not least because at the moment, unless the Secretary of State announces something whilst I'm not at the ranch, at the moment we don't have the money. But more importantly, even if we had the money to build new wards, we don't have the staff. And that doesn't mean that we're trying to cut staff. It just means we can't recruit them. We are a few hundred nurses short of the number of nurses we need, largely because they're not coming out of training. So our only other lever to pull in terms of creating extra capacity is to improve length of stay, improve discharge processes so that patients, when they're due to go out, actually go out on time. And that might seem a little bit transactional. I don't mean it like that, but if a patient... So if we improve, for example, our length of stays, the average length of stay that a patient stays in one of our hospitals, by half a day, that frees up in total across our 2,000 hospital beds about 30 or 40 beds a day that could be used to admit a patient from somewhere like the emergency department. So this stuff matters. 30 or 40 hospital beds is getting on for 2 wards. If we can't build new wards because we can't staff them, then this is another way of increasing capacity, especially ahead of winter. So we take it seriously for 2 reasons. I wasn't going to go into all the things we're doing because I think John probably covered that in his introduction to the work on quality improvement that we're doing, which was at the meeting yesterday. But I do want to assure colleagues that actually we are taking this very seriously because actually it's absolutely necessary for the smooth running of the hospitals, and not least it's something that we know consistently befuddles patients and their families. The point I meant to make and I haven't made is I think what comes through the report is that discharge is something that happens to patients. And I think what Michael and his Health Watch colleagues are saying is actually discharge has to be something that happens with patients and their families in terms of their planning, and I think that is heard loud and clear.
Thanks very much, Mark.
Yeah, just to kind of also, just really kind of come back and just want to be, just one point of correction, it was the Glenfield and LRI as far as the discharge lounges. And also what Health Watch kind of doesn't do is give you a really in-depth review as a service and a system. We don't have the capacity or the kind of the remit to really do that. What we do in a lot of the work that we undertake is to give, certainly for these pieces of work, it's a bit of a snapshot. This kind of is very similar to the visits that we undertake under our enter and view statutory powers, where it gives us that chance to speak to who's there at the time and give a snapshot on the day. So I wouldn't want to be kind of selling this as a kind of this is the system. This is just what was seen when we spoke to the people that were there when we were there at the same time.
Actually, that reminded me of a question I was going to ask, but I'll ask it now. Others think about what they're going to ask. I know this was published a couple of months ago, but when was the actual 18 patients interviewed? Is it presumably over a period of time?
It's as far as when they were interviewed, it was around kind of March, April time, I believe. Yeah.
Thank you, Chair. Just a couple of things, really. It just occurs to me that you saw 18 people in lounges. Now, as counsellors, one of the things we do get in our post bags is people telling us about their experiences of hospital discharge, etc. So you could actually circulate to counsellors, say, do you have any people who've recently gone through the experience who might want to talk to us? We could then talk to them and signpost them to you, which will give you a far greater survey. I sometimes think that there's a wealth of information that we as counsellors at all level have that we don't seem to want to access for some reason, just as a thought. But then coming back to the report itself, and I think it's the bottom paragraph on page 45 and the top one on page 46, one about medication, delays in getting medication, and the second one about getting the doctor's signature. Now, for as long as I've been involved in the health, I've known something about the health agenda, and my wife started her career in biochemistry 46 years ago, or whatever it was, which is a long time. This has been a problem. So we know it's an issue. So we know all one needs is a signature and the other needs to speed up medication. So what action are we taking to do it, and why has it taken this long to actually do anything? It's a known problem. The solution is easy. You can have a third-party conference call with a doctor who's sitting at the screen who can sign someone off, or you can actually speed up the medication system or use an outside chemist near where they live to provide a prescription by emailing something through. I wouldn't think it was insoluble. And this becomes a major issue because particularly if you're getting discharged from Glenfield or the General, if you're picking somebody up, you then have to have that almighty guess on how much car parking money you put on your car, wondering how long it's going to take to give them a prescription. So if you change the machines to pay on the way out like the Royal, it would make life considerably easier for people rather than the usual one of, do I go for 2 hours, 3 hours? I mean, so last time I went to the General for my appointment, and I know it's not on discharge, I guessed at 2 hours. I was actually in and out brilliantly 10 minutes before my appointment, so I could have put an hour on. But you've got no idea, and just little changes like that would help because that just frustrates patients no end, and it's a simple change to change the machine to pay on the way out.
Okay, so shall I take those in reverse order then? Pay on exit, yes, it works at the Royal Infirmary. It works at the Royal Infirmary because we've just had some capital 5 years ago that enabled us to do it. As it happens, Healthwatch colleagues have raised this previously. We were talking about it 2 meetings ago, weren't we? The reality is we know that pay on exit is better all round, but it will cost us somewhere between £500,000 and £750,000 to install pay on exit machines at the General and the Glenfield. And frankly, such is the dire state of NHS capital, that never makes it to the top of the list of things that are going to be invested in. So I was talking to one of your council colleagues earlier on. You'll have seen in the Mercury today, the X-ray machine at Hinckley's gone down. It will cost £250,000 to replace. We are always going to, I'm not promising we can do that, but we're always going to prioritise that kind of medical equipment over things like pay on exit until we've got a bit of headroom in our budgets. And I know that's a harsh message, but it's the nature of the game at the moment. In terms of your kind of first point around this has been around since Adam was a lad in terms of a problem, I think you're right. Just to explain it, one of the things that is slightly frustrating and working on at the moment is, and it's about helping patients and their clinicians understand what people are saying and what it means. So a doctor will do a ward round and say, Mrs. Smith, you're good to go. Mrs. Smith then thinks she's going to go within half an hour of that decision being made. What the doctor, perhaps more in a more nuanced way, ought to be saying is, Mrs. Smith, you are medically fit to go. We are now going to start working up your drugs to take home. If you need a package of care putting in place, we're going to... And that's a slightly more nuanced message than... Because Mrs. Smith here is right, I better start packing my bags. So that's one point. It's around more effective communication. Second point is we have a bit of a mixed economy in the way that ward rounds take place. So we've got 114 wards across the trust, and each one of them is a bit, has a culture in its own right. It works best when those people leading the ward rounds will write the medication request, the pharmacy request up as they do the ward round. So they see patient 1, write up the request, see patient 2, write up the request. Traditionally, custom and practice is actually those medication reviews get handed off to a junior doctor and they happen at the end of the ward round. Now, some ward rounds can be taken place in about an hour, depending on the nature and the complexity of the patient. Other ward rounds might take until after midday, so that builds in a delay. As a consequence to that, one of the things that we're doing in the improving discharge process is putting pharmacists onto ward rounds so that they can write up the prescriptions for drugs to take home there and then and try and speed up the process. Because when we've looked at it over a number of years, the original thought was that maybe it's our pharmacy teams back at the dispensary that are creating the delays, and actually in 90% of cases that's not where the delay is. The delay is in the writing of the prescription in the first place. So those are some of the things that we're trying to address.
Yeah.
If I may just come back on that point, and obviously I've got point 1 that no one's responded to, about using counsellors to provide introductions. But I suppose this goes to the nub of what I've never understood. What you said is that each ward has a culture, each ward has a way of doing things. Well, I'm very sorry. You give people an instruction, you say, that's how you're going to do it. You've got your iPad, you tick a box that says you're ready to go. You've got the pharmacy with the person. So why is it we don't seem to want to manage the system and just let people do whatever they like for as long as they like without ever changing it?
Okay, Councillor, I mean, that is based on part on a premise that actually our technology systems are fit for purpose. And if you're comparing us to a private sector experience where every ward has accessible patient information via an iPad that can then ping off a pharmacy prescription, we are light years away from that at the moment. So anybody who's been around the NHS for a number of years will know that every national NHS project to try and create an electronic patient record which links to pharmacy, which links to primary care, the NHS sadly nationally has spent billions on it and it hasn't worked. So the basis of the kind of thing you're talking about, which would make this kind of automation easier to do, just isn't there. We currently, as you will know if you've been into our hospitals, and we're not alone in this, are still wheeling round patient records in essentially shopping trolleys because we're not, we don't have an electronic patient record yet. But the more to the point around the kind of command and control issues around, okay, if you've got 115 wards, 16,500 staff, 3 sites, working 365 days a year on 4 shift patterns, it is not quite the same in the NHS to be able to say thou shalt do it this way, not least because the people who run the NHS, let's be absolutely honest, we are in the main not clinical, and our ability to say to a clinician actually that is a better way of doing it than that always has to be tested by clinical nous. Now in some instances we will push that, and in other instances the clinicians will push back and say that might be the right way to do it, but there are this and this reasons why it won't work in this particular circumstance. It's not an excuse, it's just those are the facts. When you have a highly professionalised industry, you can't always apply the kind of standards that I am used to in previous private sector experience.
Just on that point, I think we're conflating two things in some ways, and sorry I mentioned the iPad, that probably caused the problem, is if we're saying the doctor goes round, he sees Mrs. Smith and says you're good to go, if at that point he had an instruction, his piece of paper that says you sign that bit of paper now saying she's good to go, you've got the pharmacy following them around, all right, they're not going at that moment in time, but the instruction is nothing to do with their clinical ability, it's just saying you have decided clinically they are good to go, you are the doctor, quite rightly, it's their decision, I don't want anyone else discharging me, sign this piece of paper at that time, you've solved half the problems you've been talking about. You've now got pharmacists going around with them, which makes great shape. So most of these things are nothing to do with technology or electronics. They're just doing with best practice. You know, they can have a little tick sheet that they go round for patient and say, have you done that? And all that needs, surely, is a management instruction to achieve.
I think probably somebody once said that feedback is the breakfast of champions. So I have no problem, given that we are all taxpayers, we will all use the NHS at some point, and we all have a stake in its future, with robust conversations about this. Why don't you come in and see what happens, and if we can learn something from that, and your kind of challenge makes sense, then we'll learn something from it. But Michael referenced Jill Staton and Alison Taylor, one of whom works in my team. We'd be delighted to show you around and talk about some of the issues that we face. That's not an empty kind of like rhetorical device to get out of trouble.
Jerry, for me, just to address the first point the councillor raised, just about the if you ever come across any constituents who want to share their experiences, we are absolutely an open door to any of that. What I can certainly make sure is that kind of during the kind of initial planning stages, I do tend to meet with the support services to kind of discuss our work programme and just make sure that when we're then at the point of kind of sending out, if it's a survey of that kind of thing, or that we're looking for people to interview, that is then fed through the democratic services, so that gets in front of yourselves as well. Because the more people kind of trying to feed people into this, then yes, that's how we get much better sample sizes. So I will snap your hand off on that one.
Yeah, I think actually Amanda's next. But just before I mentioned that, some of us, as Mark said, were here yesterday at the joint health overview scrutiny, and we did have a presentation from John Adler and the new quality director, or whatever he's called, I think. And there are a lot of stuff which you haven't had a copy of, but which in this particular thing talks about discharge, talks about the e-hospital, but they're all down the line a bit. But this is 3-year strategy. But a lot of it, we talked about yesterday, was actually good, but you're quite right. I mean, all those sort of process matters, which, you know, you think, hang on, this is common sense. Actually, that's what they're now looking at. And we haven't really had that before, which is a good sign. Anyway.
I mean, I think there's a couple of questions, actually. I suppose the Health Watch, in terms of the voice of the patient, I'd be really interested in how that sort of dovetails with the voice of the colleagues who work actually within the hospitals on the discharge process. Essentially, they are the eyes and ears of the patient most of the time. It'd be interesting to see how their experiences may well mirror the experiences that you found from the patient. I think, obviously, you know, having had the opportunity to be involved in joint health scrutiny yesterday, John Adler certainly did go through some of the improvements to tech that is planned in the hospital. And, you know, I think it's a long time coming. I work for a housing association in my real life, and, you know, we certainly don't get it right in terms of technology, and it is really hard work to get those improvements, and we're only a very small organisation. This is huge in comparison. I think one of the things that's really interesting, and particularly from yesterday, was about how all of these things now are interconnecting quite well. And it's actually how the improvements that are planned at the hospital feed into improvements to discharge. When will you be going back to check that improvements have been made or against your recommendations? So it's really about feedback going forward, and how do we get the voice of the colleagues who work in the hospitals involved in this as well.
It's worth kind of mentioning that as part of the kind of myriad of meetings that I mentioned earlier that we kind of go to as Health Watch, one of them is the Discharge Working Group, which is a part of the Better Care Together kind of programme that's happening. So that's a kind of multi-organisational group, and this report is something that I'll be kind of taking to the next meeting of that, just to kind of talk through in a bit more detail. One of the points that we kind of do with this is the kind of part and parcel of the work that we do is that focus on patients. That's why we are funded, to kind of focus on patients. But we would absolutely and always try to have a conversation with those who are delivering services, because quite often when you're talking at the coalface, they are experiencing things that they then maybe don't have or feel that they've got a way to then kind of share those experiences. So kind of feeding them into the work that we do gives, as you quite rightly say, a very kind of important perspective on what is the reality for patients using services. We, through our chair, Harsha Kotecha, who actually sits on the UHL governing board, the points that are raised in here should be kind of then taking it to the governing board to actually then put it in front of the board themselves to say, look, these are some of the issues and realities. And I suppose it's then for UHL to kind of pull that together too with what they know as their kind of workforce experience of the services. But as far as kind of going back into a service, we'd probably normally kind of go in about at least a year, unless there was kind of other more important things that kind of came out of it. But kind of given discharge and its priority not only from patients that we speak to but also from stakeholders, and kind of how much of a priority that is, I can't see this going anywhere as a priority. So.
Tom.
Yeah, you're obviously making efforts. I think the majority of people who go through the health service, I would say this, are quite satisfied with the service they receive and the medical attention they get. And I think some of the medical practitioners are not as open to management as other individuals, because their priorities are based on the patients, and what they may see as being inconsequential actually does have effects down the line of the number of hospital beds that become available if you get it right. And I think over time they will probably begin to realise that, but with the majority of discharges coming from the wards rather than through the lounge, I think patients who go to the lounge are probably, their experience is tainted by that. So there really is a real incentive to get this right for numerous reasons, but I think it's a question of educating in a different way, or making the medics aware that how important it is, that it isn't just a silly piece of paper or something like that, that it really does have impact on the service they're able to provide, and on the patients, and on the patient's perception. Would that be a fair comment?
I think that was a slightly rhetorical question, Councillor, but yeah, yeah, it would be a fair comment. I'm going to get philosophical now. Such is the rapid changing nature of the way that medicine's practiced, that if you look at our clinical colleagues across the system, it doesn't just have to be in hospital, you know, there are still some clinical colleagues who believe that post-surgery bed rest is a good idea. There's something in the news today about we are now getting people mobile 24 hours after a hip replacement. Now, previously, a hip replacement, you'd be in bed for a week afterwards. Medicine now teaches you that actually being in bed for a week after a hip replacement probably kind of doubles, triples or quadruples your chance of getting some kind of horrible embolism as a result of blood clots and lying down for too long. I wish it were the case that you know, professionals, you know, myself included, you can't just click a button and say, right, that's you reprogrammed to the latest medical practice, you know, or things change at differential rates. Your point about most people who come into contact with the NHS have a decent experience of the service, I think is right. We, you know, our friends and family test, which is like TripAdvisor for NHS hospitals, rates amongst the best in the region. Especially in our emergency department, and yet our waits to be seen in our emergency department are still too long. But the point is, when you've got a trust the size of UHL, where we see 1.1 million patients a year, even if you get it wrong for 5% of those patients, that's still a very large number. So we can't take false assurance from the fact that 95% of the time we're right and 5% of the time we're wrong. So there's a lot still to go at.
I'm sorry. And I kind of absolutely kind of understand that the kind of doing the work that we did in the discharge lounge has given us a perspective on what the patient experiences in the discharge lounge. But some of the experiences that are shared kind of outside of this do demonstrate that the discharge process within wards isn't perfect either, as Mark has alluded to earlier. And I think one of the things that Healthwatch and anyone really can have a responsibility for is to better educate members of the public about what the right questions to ask in that scenario. I mean, I remember taking a call from a member of the public only a couple of days ago, and they were in a ward. They want to get their parent out of the ward, but they don't know who to talk to. So it was just that kind of like arming them with the information to be able to make the informed choice. I think is a long-term goal for kind of what Healthwatch is about, and how Healthwatch can support the public to be able to kind of better engage with the services and have a more meaningful discussion and relationship with the services they use.
Right. Forgive me, I don't know whether this is the right place to request this at all, but yesterday we had a 3-week, that would be good, wouldn't it? 3-year plan for becoming the best. And the staff recruitment was mentioned, not in depth there. And we've just heard again how hard it is to recruit nurses. And I realise that recruitment and training for nurses is an issue nationally. However, I would like to be able to scrutinise the actions that have been done, can be done, to alleviate the problem, i.e. Employing more ancillary staff or admin staff. And so I would like the opportunity to see where the gaps are, where the problems are. And I think I know where the gaps and the problems are, and it all starts with funding and for training. Yeah. But I think we owe it to ourselves to scrutinise that and to see if we can speed up a process or something, just to see the problem as the bigger picture, because this 3-year plan isn't going to work without the staff there, without the ground staff to make it work. I know we're talking here moving staff from one hospital to another one, so we concentrate staffing more, but of course we're going to see more patients, so even though we're concentrating the staff, we still need more staff. So I'd like the opportunity to scrutinise it, please. Thank you.
And I think something our officers, Rose was nodding, looks like we're... Well, thank you very much, Michael. That's very good. I mean, 2 of them... Oh, sorry, David.
With looking after, or trying to look after close family relations. And I think looking at some of these comments here, I do wonder whether they should be taken with a pinch of salt in some cases, because the impression I get is that people don't always realise what's happened to them or what they're going through, or so people will sometimes complain about the food to somebody who just saved their life. Yes, sorry, Chairman. I'll leave it at that.
I appreciate what you're saying. I mean, I know certainly, Mark mentioned at the start, I mean, it might be better if they had to communicate rather more with the patient while they're letting them out the door, to say when they're going to let them out the door rather than just, yes, you can go home. I think that's very much part. I mean, certainly when I've visited the Royal, as I have many times when I used to work down there as well, and I'd go on wards and there'd be someone, there's always someone, no, not necessarily old, actually, could be young as well, but sitting sort of on a chair halfway in the ward. And I'd say, hello, how are you, whatever, just waiting to go. And that was, they could have gone to the lounge, of course, but the bed was being changed, and so they got out of the bed, and this is years ago. I mean, I'm sure it's far better, but it is obviously a process that the report has raised with us, and thanks very much, Mark, for coming to give us some of your responses. So thanks very much, everybody. You can go and meet the Secretary of State now and CQC. Perhaps he's going to give us all that money. I do. I think we'd have probably heard about it by now. Yeah. Next paper then is agenda item 10 on page 51, and this is the health performance update, where we've got Andy Brown and hordes of people. That's Kate, isn't it? Come to talk to us about where we are on the particular measurements that they've given us today. Who's going to lead then, Kate or you, Andy? I think so.
Yes, thank you very much, Chair. The report before you today aims to provide the committee with an update on the health performance system in Leicestershire and Rutland based on the data we had available in August. It isn't all actual August data, some of it is older than that, but it is all of the data we had available in August. And the aim of the report really is to provide an overview for the committee of the official data to enable you to ask for further reports, information, to understand the system, inform discussions, and to check against other reports that are coming through to the committee, such as reports on the agenda today. In relation to the construction of the report, it was based on the mandate to the NHS issued in 2017-18, and interesting to note that there hasn't been a mandate in that form issued since then, but we have kept some of the metrics and amended that accordingly in the report. And also a wide range of separate clinical and regulatory standards and frameworks that apply to different services, such as the Public Health Outcomes Framework, the Adult Social Care Outcomes Framework, the Better Care Fund guidance, and the CCG Improvement and Assessment Framework, which is covered later in the report. We have also sought to include some extra information that the committee has asked for, particularly a wider range of cancer metrics and information on never events and serious incidents relating to UHL. In relation to the framework, we are looking to add to the framework moving forwards, and a new dashboard is under development with a wider range of metrics, particularly around the Better Care Fund and integration work. Given the scale of the budget and the work around integration now, there's a feeling that a more detailed dashboard will be useful, and that's being considered initially by the Health and Wellbeing Board. And certainly once that's developed, I think that may be of interest to this committee as well, and I'm happy to bring that through and to see if that will be useful to you. And there are also some changes going on in the wider health system around reporting, particularly at the STP 10-year plan level, and also in the NHS, which Kate will come onto in a minute. So there will be some changes moving forwards, and we're keen to make sure the report you're getting is very relevant and focused on the key issues. And if the committee has any particular points it would like us to sort of pick up moving forwards in those frameworks and have information on, I'm more than happy to sort of take that back to that process. So at the moment the report's based on three key dashboards. One is around the Better Care Fund plan and integration, one's the more detailed CCG IF framework, and the other one around public health key outcome metrics. For the Better Care Fund element, you may be aware that there was a refreshed policy framework for the BCF published in April 2019-20, and then the final guidance was published in July. So the team has been working hard on the revised Better Care Fund plan and the necessary allocations, and also the performance reporting and metrics related to that. In relation to the performance framework, it's very similar to the old guidance in that there's four key metrics that we have to report on. and also a strong focus still on delayed transfers of care and the speed of transfer. Last year, in Appendix 1, we've set out the final results against the BCF metric targets for 2018-19. And the good news is in relation to that plan and the activity that's been underway, all of the targets for BCF 18-19 were achieved. So there were good reductions, particularly around delayed transfers of care, and we stay within our target range for admissions of older people, the operation of the reablement services, and then non-elective admissions. So that's Appendix 1, that's the 18-19 figures. So that's good news for last year. In the first half of the report, we look at the current sort of 3-month figures for the metrics moving forwards, and we also set out the revised targets that have been set for the Better Care Fund plan. So we have refreshed the targets to make sure that moving forwards we've got a strong position and strong delivery. The first one around admissions of older people 65 and over to residential and nursing care homes. At the moment, there has been 218 permanent admissions between April and June, and we've got a forecast taking that forwards to be around 853, which is around about the target. It may be slightly over the target, so we're monitoring that closely to look to influence it, but pretty much close to the target position so far. Similarly, in relation to older people who are at home 91 days after discharge into reablement services, good performance position in the first 3 months of the year. We're currently at 90% of people discharged still at home after 91 days against a target of 88%. Delayed transfers of care, metric 3, we were reporting last year sort of really strong performance around that metric, and we've seen significant reductions in that speed of discharge last year in the system, and a lot of work that's gone on around that. In the first 3 months of the year, we have seen a move back in the opposite direction in part. So from April to June, there's been a quite significant increase on delays compared with the same period last year, particularly around LPT and out-of-county delays. I think UHL seems to be maintaining a good position there. So there have been sort of steadily increasing delays from November 2018. So the system is sort of looking closely at the issues around that to see whether anything's changed or whether that's to be reinforced again through BCF monitoring and the integration executive. So just sort of have a watch on that overall. So there has been some good improvement, but just to note there's some sort of pressures around that at the moment. And then the final BCF metric around non-elective admissions into hospital. So far, first 3 months of the year, we are within the variance that's been set, I think 180 underneath the 17,000 odd admissions. So that's being maintained within the CCG planning framework. So that's a bit of a snapshot around BCF 3 months in. Happy to take any questions or hand over to Kate for the CCG part.
That's a good plan. Anyone got any points on that first section then? I mean, really, that we've set.
I think the delayed transfers of care comments about LPT out of county and our own adult social care is something we need to keep an eye on, because it was fantastic last year. Things went really well. I know LPT on and off has been an issue for some time, but the fact that adult social care is attributable, I know it's from a very low base, but I think that's something is concerning if it carries on going the wrong way. Thank you, Chair.
I think it's a comment, really, isn't it? When we had our chair's briefing a bit earlier, you'll notice on the graphs here, the days delayed, and also obviously the non-elective ones, the red line that goes across the top, the days delays targeted, so on, and the fact that it's not straight. Sarah clocked onto that, exactly why that is. It's related not only to the particular point it's talking about, but also the number of days in a month. The little dip at the end, which is February, gives the clue. So we all know about the April, September, all the ones with 30 days. It's simple thing, really, isn't it? Just one of those little minor things that you think, why is it wiggly? Simple. So we've cottoned on that. Anyone else got any points about this particular first section before we come on to the CCG performance dashboard? Okay, thanks very much.
Okay, thank you. So as Andy outlined, we are expecting to see some considerable changes to the way that CCGs are monitored, and NHS England provide the assurance. So the paper that I've presented here is based on the 1819 assurance framework. Just last week, NHS England and NHS Improvement issued a new NHS oversight framework, which we're still looking at and still trying to understand. It's fairly similar in terms of the metrics that we're expecting to report to CCGs on. There are some new metrics, so again, you'll see that coming through in future reports to your committee. Also just wanted to mention about performance reporting going forward into the next financial year. At the moment, CCGs, well, the whole system actually is working quite considerably hard on the 5-10-year long-term plan, which is why we haven't got a CCG representative here, unfortunately, today. So what we're expecting to see is that NHS England will expect CCGs and systems to report on the new metrics that are contained within the long-term plan from next financial year. And that could be quite a challenge because there are a considerable number of new metrics in there, ones that are completely off grid. So as I say, we're currently working on producing a 5-year trajectory for that, and then that will form the basis of reporting it in future years. So back to the report, I'll just take you through. I'll take the report as read, but I will pick up on a few comments that I think are important to you. So the framework that this is based on was published in July 19 by NHS England. So within the appendix, some of the data is a little bit old. So again, I've provided a bit of an update to that information. The framework is used by NHS England to rate CCGs, and in 17-18, East and West Leicestershire CCGs were both assessed as requires improvement. However, in recent months, about 3 months ago, I think, the 18-19 assessment came out, and they were both actually reported as good, which is a real improvement. NHS England cited various areas of strength, so that includes the smooth transition of the West Leicestershire leadership changes, the progression of some corporate functions working more closely together, positive engagement with the STP and system level activity planning. But they also recognise that there were significant financial pressures on the whole system as well. So going through the constitution metrics, which are in the table starting from paragraph 21. The first one relating to the 62-day cancer metric. Again, some up-to-date information available now. There has been a small improvement now that we've had the July performance data out, but not significant enough to be meeting the national target. Main reasons around not meeting the target are these late tertiary referrals. So that's when we've got one consultant in a hospital referring into another consultant, and there's obviously the potential for delay there, particularly around some of the long waiters. Cancer patients are tracked until they're treated through the system, and CCGs are appraised daily on the status of those cancer patients. Moving on to A&E. So again, the July data is within the paper. Just to update you that, again, no significant improvement when we've got the most up-to-date data, which is actually as at yesterday. September, we're looking at around 73% of ED attendees being seen and treated within 4 hours. And urgent care centres are exceeding the national target, so around 99.7% of patients. So good work continuing to be there. Again, within the paper, there's a number of actions that are being undertaken at UHM. Moving on to the referral to treatment target. So again, not meeting the national target, although there's the additional target of reduction in the waiting list, so the number of patients that are waiting. And we have seen some improvement, and across the 2 CCGs, they're within the plan that the CCGs have got. So hopefully by the end of the financial year, then we'll see a significant improvement in the number of patients that are waiting. around that, the cancer referrals into UHL has had an impact, and clearly the 2-week waits are diverted to support those particular patients. Some actions underway include recruitment, additional weekend lists, and we're continuing to work with the independent sector. There's also the referral support service as well, which has helped to reduce some of the demand going into UHL and the Alliance. The paper also includes a table showing all of the cancer metrics, and again there has been some improvement in the July position, but not enough to really warrant any changes in RAG rating. Section there, 23, around UHL Never events. So at the time of writing this, there had been no Never events within UHL, and the number of serious incidents were low when we compare it to other similar providers. I also wanted to flag some of the areas of improvement as well. The lights have gone on. The diagnostic weight standard has been achieved at UHL for 10 consecutive months now, although the CCG performance is not at the national target, and that's due to the out-of-county providers, particularly Derby and Nottingham. So unfortunately that's dragged the performance down for the CCGs. The 52-week waiters, there have been none across UHL for the past year. So that's good. And then moving on to DTOC, we talked earlier about the discharge, and actually UHL do remain within their tolerance levels, and East are within the highest performing quartile across England in regards to DTOC. Similarly for East, they're performing well on the number of women that are smoking at the time of delivery, so they're in the highest performing quartile for that. And those of us that have been around the table for a while, dementia continues to achieve the national standard. So I just wanted to end on some positive news, really. Okay,
Thanks,
thank you.
Kate. Yeah, Terry.
Thank you, Chair. So I'm a late substitute for this committee, so you have to bear with me. And I've read it cover to cover, but I couldn't find it. I have no idea what a never event is. Here's question 1. Sorry? Right, that's fine then. Right. So my main question then is regarding the table on page 61 regarding cancer, and it's also covered in the chart on paragraph 21 and 58. It's about the 62-week period. It's when it starts that concerns me. So in this day and age, due to the inability to get an appointment with a doctor, invariably you see the practice nurse first. So I'll give you an actual example of this. So a very good friend of mine saw the practice nurse who said, you must urgently see a doctor because you need to be referred to the hospital for cancer. So the nurse couldn't book an appointment for her, so she goes round to the reception. The receptionist says, I can give you an appointment in 4 weeks' time, and refused to budge. It was only because she knew one of the receptionists who phoned her up a week and a half later that she got the appointment. And she was then at a consultant within 2 days, operated the day after that. That's how urgent it was. So it cannot start from the GP referral. It must start from the first appointment at a GP's surgery. Because if we now accept that practice nurses are now doing a lot of this, it should be from the point of referral from anyone in the GP's surgery. Because that person could have actually lost 4 weeks, and had they not known a receptionist, I have grave doubts about whether they would be with us today. And therefore, we've really got to do something about, and they've got records, so GP's got records, they would know this person was in, they would know when they saw the practice nurse, they would know what the practice nurse recommended, and therefore there has got to be a way for the CCG to actually prioritise these when their own practice nurse says this should be prioritised. And therefore, I find it difficult in the light of an actual experience to believe this chart because it's starting at the wrong place.
I completely agree with you, to be honest. It's a national target, so it's set nationally, so that all organisations can be compared and benchmarked against each other. And it may well change over time as you see other practitioners making referrals in, but at the moment it is from that GP referral.
I can understand that slightly, and my father lives in deepest, darkest Lincolnshire, and my children live in Norfolk. They ring up the doctor in the morning. My father, if he rings up at 9 and hasn't got an appointment before 3 in the afternoon, thinks he's been hard done by. So you can have a national target, but on the basis that access to GPs is not consistent, we cannot, and CCG should be going back and fighting against the national target, because it should represent local circumstances. And I think we need to add our voice to that.
Yeah, I'm sure if somebody from a CCG was here, they would talk you through changes within primary care and online consultations. Again, part of the NHS plan is around technology supporting primary care. So I do think we'll see a lot of changes, but I can feed that back through the CCG. That's fine.
Yeah, thanks.
Thank you, Chair. Picking up what Terry said, I think your friend should have complained bitterly because I think that's horrendous. Anyway, I wanted to understand two things. One is I wanted to understand what late tertiary referrals actually meant. Does that mean you referred from one cancer specialist to another, or you go in with a bad back and then they find 6 months later it was actually cancer? So I want to understand what that means in more detail, because it's, I don't quite understand what that means. Now, my other point is on page, for example, 68, 69, the detailed reporting, which I like. I like the fact there's little ticks telling what's new data. I like the fact it's colour-coded. However, and this is a pet hate of mine, take, for example, provision of high-quality care. Provision of high-quality care hospital, 54. 54 what? Lemons, bitcoins. I mean, and that information, whilst it tells us it's the worst quartile because of the colour, is meaningless. I would just like you to point that out to them, because it really annoys me, and I would have got into a lot of trouble doing that in the past. Thank you, Chair.
Yeah, that's fine. So on tertiary referrals, I can get the actual definition for you, but my understanding is that it's from one consultant, so it's still on the cancer pathway, so it's from one consultant to another, coming into our hospital, essentially, or our patient moving from one hospital into another hospital. Sorry? Yes.
Chair, that slows everything
yes, it
down.
Does.
Right, back to your point. Okay, thank you. Yes, it's good to know, so we can understand what that actually is.
What I will do is I'll get the actual definition, though, just to make sure that that's fine.
Cheers.
And then, the dashboards. So these are produced by NHS England. They're scores. I'm not quite sure who scores them, but yeah, again, it'll be the consistent definitions across the country. So in terms of, as you made the point. Same here. Okay. All right, thank you.
Yes, it dawned on me that had actually when I was looking through them, because I spotted O3W and O whatever East Leicestershire is, because the codes I used to use when I was working at Northampton to put code stuff off to send it off to nationally, so I could see where it all comes from. I worked out.
I think just following on from Terry's point with regards to the cancer metrics, I think one of the things that's really difficult, and particularly in the way it's presented, it tells us what the national target is and it tells us what the local performance is. What I don't actually appreciate from this is the national target achieved anywhere, or is it just a floating target that nobody really achieves? What is the actual benchmark position at the moment for the 62-day wait nationally? Is it 85%, or is every trust underperforming? The other thing that I wanted to sort of just work through a little bit is the difference between the performance of East and West, because obviously my assumption is they're referring into the same place, or could be. So I don't understand why, particularly on the 2-week wait for the urgent referral breast symptoms, East is meeting national target, West is quite a long way off. And there is quite a big difference between those two numbers, and I don't know if there's been much work that's gone into the detail of that, of why East is outperforming West, and when we're going to get some kind of levelling off of that. Thank you.
So both questions are kind of related really because it's around the peers. So first question around the overall cancer metrics. We produce quite a lot of information on peer groups. East and West are actually in the same peer group, so their demographics, the gender profile is fairly similar, and there are 10 other 10 CCGs within each peer group. Interestingly, when we come to working on systems, Leicester City is in a completely different peer group, but we're going to deal with that at some point. We also produce there are also provider peer groups, so UHL are in a group with other similar providers. So again, information is available on that. I mean, again, next time, or I can do something separately, I can show you kind of how CCG peers are comparing to each other. And then in terms of the difference between East and West, they are sent to different providers, so that will be the difference. So across West, generally it's about 25% of activity doesn't go to UHL for West and for East. So the West providers will be Nottingham, Coventry and Warwick, George Eliot, Derby, and then East will be Peterborough, Kettering, somewhere else. Northampton, thank you, yeah. Is that North West Anglia, is that one as well, I think, yeah. Ah, okay. So that's why there'll be a difference between the performance activity.
Come back on that. I mean, I think that's really interesting. I think what would be really useful from a scrutiny point of view is to understand the stuff that's in our control, i.e. the responsibility of our hospitals, and the stuff that's outside of our control, in real terms, that, you know, it's not our providers that we scrutinise, because actually if the impact is actually with one out of area provider, then we really need to be doing some work with those. You know, it would really concern me if it's actually those individuals being sent to Nottingham, off the top of my head, is actually what's causing the West numbers to wobble. Then we obviously need to understand the impact on our local population here in Leicestershire, and whether or not they'd be better placed to actually be referred into UHL if UHL is outperforming the out-of-area providers. I'd be really interested to see how those numbers extrapolate out.
So the CCGs are well cited on that sort of information, so we produce out-of-county provider reports to them, and in most cases we can drill that down to CCG level patients so we can see it, and generally the numbers aren't huge, but that information is out there, so yeah.
That's useful, thanks, Kate. I mean, we had, as we mentioned before, we had a joint health yesterday, which is not just the city but also Rutland. Now, of course, Rutland are part of East Leicestershire and Rutland, but the lady from Rutland County Council does make sure that everybody knows that Rutland is different, 38,000 people, etc., etc., etc. In a way, if she was here, I'm sure she would make the same comment. But from her, the out of area, of course, it's often Peterborough, and she made lots of comments about the fact that, you know, it's very difficult to control what goes on from their county council when it goes from Peterborough. But yeah, it'd be very useful to actually get that sort of information. Thanks very much then, Andy. And no, got next bit, haven't you? Sorry, forgot that. That's the next. Gosh. You've got the public health bit. How did I possibly forget?
Yes, just to finish off with the public health part. Appendix 3 contains the dashboard containing 38 indicators related to public health. It's not the full public health outcomes frame, which has 100 plus indicators, so it is a subset of areas that are particularly important. There's particular focus on relate to some of the services that public health and interventions public health are working on. So that's set out in Appendix 3 with statistical significance and areas of improvement. They're the sort of metrics that don't change rapidly given the kind of ingrained nature of some of the issues in there, so we don't tend to see a huge amount of sort of change to report to you, but just to pick out one or two issues. Overall, there's 18 green metrics, 11 amber and 4 red in terms of the benchmark positions. Of the 18 green, there's been some really good improvement over the last few years in a number of them. Under 18 conceptions, particularly 67% reduction since 1998, which is better than the national picture. Latest figures just 135 conceptions. New sexually transmitted infections and smoking status at the time of delivery has also shown significant improvement. Areas that have been declining are breast cancer screening coverage and cervical cancer screening coverage, which I think are more NHS England commissioned services, which rather than sort of Leicestershire Public Health. Paragraph 28 of the 11 amber indicators want to flag. We've got a very well-regarded and well-rated drug provider. I think it's got one of the top CQC ratings. But drug treatment for opiate users, which has been an issue for a little while, is still sort of being flagged as a focus for that service. So that's a priority area still moving forwards. The 4 red indicators, chlamydia detection rate, which we've sort of flagged before, which is one of those more difficult indicators to do with whether it's sort of prevalence or sort of detection, and the kind of the blend between those two. But it's certainly flagged as an issue, so that's still in the improvement framework. Take up of NHS health checks. We've been flagging for a little while. There were some changes around how health checks were incentivised in the contract, and I believe there's some discussions nationally about more targeting of health checks moving forwards, which I'm sure if it needs to be Mr Sands could sort of have some more information on. Physically active adults, we're flagging in the report where there's been a slight reduction in the survey methods for Leicestershire active adults, down from 66.2% to 64.3% in 2017-18, and now just below the national average. There is a lot of work that goes on through the Unified Prevention Board, working with district councils, Leicestershire and Rutland Sport, around that area, but that's still sort of flagged as an improvement priority. And then just to mention on the child obesity figures, I think we reported last time around that there'd been a collection issue in one of the areas which had affected the figures. That's still in the figures, but due to drop out next time round, so we will have a sort of a better picture of that next time we report back to you, which I think comes out nationally in October, so probably the next report we'll have that. So that's all I wanted to mention. I don't know whether Mr Sands had any particular comments.
Yeah, thanks. Yeah, Brenda.
Thank you for that. Just because I'm a new girl on the block, I would just like to ask why different dating periods in all of this data, please.
It is to do with some of the complexity of when data is released nationally. So there are some sort of quite long lead-in times for data to be collected and published via sort of providers. Sometimes there is a kind of natural lag in the data. For example, in sort of teenage pregnancies, where some of the data obviously gets reported much later on. So there is quite a complex picture of data flows. Some of it is more kind of in year that we have access to, but quite a lot of it is delayed data because of that chain of reporting, collection, sort of cleansing, and then return from government. It does cause one or two issues, so we would like to improve that, and that's part of the digital agenda, is to try and sort of work together to speed up some of that reporting.
I particularly looked at the infant mortality and wondered why that can't be done on a closer period, because that was 15-17. But I thank you for your response. The cancer screening, all of the screening coverage, obviously we all expect it or would like it to be 100%. Is there anywhere data collected or collated that the amount of people that just don't turn up, because we'll take the first one, which is cancer screening, breast cancer screening. Is that because they're not turning up, or you're not, or is it? I don't know what I'm asking to really. Is there another hold up besides them not turning up, ignoring the request?
I mean, many and varied. I don't know if I can answer your question expressly. As Andy pointed out, cancer screening isn't my responsibility or the county council's, it's NHS England. One of the things I do regret in the Health and Social Care Act is it kind of lost that ability to do local work. So if you're really going to get people to take up a cancer screen offer, you wouldn't just focus on the appointment letter that drops through your door, you know, and all the rest of it, or even a national campaigning. You'd be wanting to do local stuff. So you might want to target doing campaigns through hairdressers and all that kind of business. So a lot of the kind of NHS England stuff, and it also applies to things like TB screening and what have you. You know, you would want to have a stronger relationship between NHS England doing the kind of invites and all that kind of jazz, and staff on the ground, be it, you know, my staff that work in communities or the role of local authorities more generally. And one of the things I think I want to do with the NHS long-term plan is to reinforce that message. It wasn't actually about cancer screening, but I know Public Health England colleague, not Helen, is in the audience. A trainee did a piece of work on another area, and it was almost like, and the way we're going to get this sorted is by engaging more with local authorities, because that's where the levers are to actually work with people to understand why it's important, where they need to go, and all the rest of that stuff. That would be a big step. You know, it's almost the softer stuff, you know, less about systems and processes, more about what you do locally to work on the importance of it, addressing some fears that people have about the acceptability of tests and everything else, and the risks and benefits.
That can't access in the day, so it's easily discounted, the letter, and they don't turn up. But if we could offer that sort of thing at night or in the evening, so, but I'm not quite sure where that discussion went with the doctors, whether they were reluctant to it, because they seemed, oh yes, that's a good idea, but then it just went very quiet after that. So
I think again it would need probably a conversation between NHS England and the CCGs and the GPs and maybe the local authority as well. But I mean, it's not impossible, but it obviously needs a bit of resource, and you know, I mean, the things we've been a bit targeted on other stuff like some of the earlier items. But I mean, you know, there are things. You know, we've got some investment coming from the Cancer Alliance for the East Midlands to help us do some prevention work, and that's the kind of thing it'd be nice to get into.
Yeah, I was going to say we've got now, of course, vaccination of cervical cancer for boys and girls now, isn't it? I mean, that's now rolling out, I see. Michael.
It's all right, Chair. I've just remembered what's coming up in the agenda, so I'm going to ask my question slightly later.
Amanda.
Thank you. I'm going to ask this question. I've asked it a few times before, but I like to repeat myself. So breastfeeding has a 2.0.2i breastfeeding initiation has got a null result, and my understanding is that's because we don't have an appropriate collection method. Is there going to be a point at which we might get an appropriate collection method? Because I think one of the things that's really important is the messages that go across in terms of breastfeeding and the impact on the infant, the impact on childhood life. Yet if we don't understand what our starting position is, it's really difficult then to track that through the infant through to child. Thank you.
Yep, I did actually think we'd sorted that one and the data was back in. Yeah, it was to do with a problem with the health visitors asking and the collection of the data, and we fell just below the minimum requirements for data quality, and therefore the whole thing was junked. I'd have to check. I know you've asked it before and I promised you we'd sort it. I thought we got that data sorted. The issue being, we still know the issues, as you know, between the difference between breastfeeding rates in the West and East. So it's not as if we're not working on the issues, it's just getting the data, getting above that data quality threshold.
I think obviously the other sort of connection is between the impact of changes to the Sure Start centres and the impact that they would have on supporting breastfeeding. We actually don't know whether or not the closure of the Sure Start centres in some areas would impact breastfeeding, because we don't have the data to start with, and that's for me is a disappointment that we can't track the impact of other measures on those kinds of things when we don't have the baseline. Thank you.
Terry.
Thank you, Chairman. Where is it? I've lost it now. The fourth one up from the bottom to 219, which is the red one, cumulative percentage of eligible population offered and received NHS health check. I just wonder what constituted an NHS health check. Is it things like hypertension clinic and things like that?
No, so that's the one you should, if you're aged between 40 and 74, be offered a health check by your GP once every 5 years, and it is the one that covers blood pressure, cholesterol, dementia, da-di-da-di-da. But, it's the one that you should be invited by your GP. It's not just randomly having your blood pressure done at a GP appointment.
I thought you said that because obviously, like most of the population my age, I'm in that bracket. I go there for my tablets. My cholesterol's perfect. My blood pressure's perfect because of the tablets. But obviously, you have a yearly check. Does the yearly check come into it? Now, the reason I ask that is because my surgery sends me a text message to say, book your hypertension clinic. Well, in fact, they don't call it a hypertension clinic now. They call it something else. No, it was something even different to that. But of course, they send you one text, and then if you don't respond to that text and go and book an appointment, you never hear from them again. So should there be a minimum requirement for them to chase you up? So the last time I got a text, I was on holiday. There's no point in trying to phone them because you can't get through on the phone. So there's no point in booking. So by the time you get back and then you go down there, that's if you remember that you've had a text, but they never send you a chaser. Now, I do wonder if it's the non-availability of chasers, which is reducing the percentage. So should there be a standardised way of inviting people for these checks across the country? It always slightly worries me that we have a national health service, but they missed the word national out of it.
In terms of the health check programme, we do have a standard way of inviting people because that's the spec. It's our responsibility to commission it from GPs, and the spec is, I forget what it is, but letter and a phone call, whatever. Well, there you go. So 3 invites. It's an unusual heckle from an audience to tell you what the answer is, isn't it? But thanks, Josh. No. Yeah. What more can I add?
Yeah, quite. No, brilliant. I mean, in my practice, we get a letter, and at the bottom of the letter, there's a bit that says, if you don't want this check, send the slip in. But it doesn't actually say, well, hang on a minute, yeah, but I actually do want it, but I've still got to do something. I've got to ring up and make an appointment, of course. But then having said that, because of my appointments tomorrow morning, today I've had the reminder by text. Yeah, it's getting the appointment in the first place. Well, we've discussed that earlier. Getting a GP, anything. I can't book a nurse, of course. I could book a GP appointment eventually, but I have to go through phone to book a nurse appointment. I mean, a lot of it I can do electronically, book GPs, but I can't book a nurse. Yeah, odd, but still. You've done it now. You've solved it.
No, Chair, it was the. I was going to raise a question around the kind of successful completion of drug treatments for opiate users, and I realised that we've got a substance misuse kind of conversation coming slightly further, so I thought I'm going to keep quiet. But as you asked, no, I'll ask it later.
I can do it now.
He's not run away yet.
So we'll see, right? I reckon the answer is that the completion rate's going down because we're getting into a category of opiate users that got ever more complex and chaotic lives. So it's just more and more difficult for them to complete treatment. But the specialist consultant behind you will, for the next agenda item, either confirm or deny my...
I'd like to say that's relevant to my question, but...
It's a 2 Ronnie sketch, giving you the answer to the question before.
4 candles?
Okay. So I think that does complete the performance report and update. Thank you very much, both Kate and Andy, and indeed Mike. I mean, you obviously chipped in there quite well. Thank you very much. So we now move on to, theoretically, I think, yes, it is our last major item, which is indeed the reports from Mike Sands and indeed his colleague on the draft Leicestershire substance misuse strategy for the next 12 months.
Thank you, Chair. Although, handily for me, I'm going to hand over to Joshna, who's the lead consultant in public health for substance misuse, to take you through the substance misuse strategy consultation.
Good afternoon. The purpose of the report in front of you today was to consult with this committee on the draft Leicestershire substance misuse strategy. The background is that Public Health led on the development of a joint strategic needs assessment with 2 chapters, one on drug misuse, one on alcohol misuse. We published those in March. They highlighted the considerable progress that we've made over the recent years in reducing the harm caused by drug and alcohol misuse in Leicestershire. But we know that the landscape's changing. We know that there are new drugs on the market. We know that cohorts and needs are changing. And we also know that there's increased financial pressures on an array of organisations. So there is a need to review the existing approach. So following publication of the needs assessment, pulling together the needs that we found in the recommendations, we thought it was timely to develop a strategy to look at how we can take this work forward. So within the strategy, we've outlined 5 strategic priorities. The themes on those on the priorities. So priority 1 is around prevention. Priority 2 is around early identification. 3 is around treatment and recovery services. 4 is around reducing harm, and then 5 is around the partnership or multi-agency approach that's required. The draft strategy went to Cabinet in June, and we received approval to commence a public consultation, seeking feedback on those priorities. At the time that I submitted the report, the consultation was still live. That's now closed just at the end of closed last week. So the feedback that we've received from numerous organisations, including and departments, including adult social care, UHL. We've had community safety partnerships within the districts respond, and then our service providers and service users also, because we've gone out and done some focus groups specifically with them. So far, what we've found from the early analysis is that the draft strategy has been well received, many reporting that it's timely and that it's something that we've needed for a while. And there was a lot of support around the partnership approach, making reference to the need to do that quite quickly. We didn't receive any feedback alluding to the priorities being incorrect or anything specifically being missing. Some of the responses focused on having a detailed action plan of how the priorities would be delivered, which was a fair comment. However, at this stage, we were consulting on whether the priorities are correct first before we go forward with an action plan or an implementation plan. We didn't want to preempt that these were it, and that's what we were doing. So although it's a fair comment, we will be doing that once we've had approval of the priorities. There was some specific feedback on each of the priorities around things that people wanted to add to it. Again, there were valid comments, and they'll things that we will amend in the strategy going forwards, but they don't fundamentally change the priorities so far from the feedback that we've got. So overall, the consultation responses so far support the strategy's proposed approach. We will make some of those amendments based on the feedback on the specific priorities, and to develop a final version, and the plan is to present that to Cabinet in November, and then following that to develop the implementation plan to sort of show how those priorities will be delivered over the next 3 years.
And I suppose just a bit of context, I should have said at the beginning. So in terms of responsibility for commissioning treatment services, that's one of the things that transferred to the County Council when Public Health transferred in April 2013. And to be fair, that's been the focus of our work. Josh has been heavily involved in that over the last few years. So we've had 2 goes at redesigning the service, ostensibly to save money because of the reducing grant. The fact we've managed to jointly commission that with City Council and with Rutland Council, and as Andy Brown said in the previous agenda item last time, CQC inspected Turning Point, it came up with an excellent top rating report. So we've done the service bit. Having said that, I suppose what we do about drink and drugs needs to be more than just about providing good treatment services for people. So we've been waiting a while for this, and I'm really pleased that Josh has got us to the point of having a draft strategy which opens up a broader conversation along the lines of, well, what do we think we should be doing more broadly around drink and drugs with our residents? So I really welcome the strategy from my point of view.
Thank you, Chair. It's not about the priorities. I do think the priorities are absolutely kind of where they need to be. It's just something that's emerging around drugs misuse and the overprescription of painkillers, which is emerging as a kind of a new substance misuse, and how you can really kind of feed that in, given that it's actually coming from your health colleagues. And just as a kind of an additional piece of context, we heard from a member of the public who had self-identified as being addicted to painkillers, and when they sought help, basically to link their GP to Turning Point, the GP said, no, we do not do that. And whilst this may have just been a very individual experience, just to kind of highlight the need to make sure that the GP services are kind of linking in to Turning Point, if that is possible, when you start to look at like the kind of prescription painkillers and that kind of addiction that's starting to emerge as a new issue.
Yeah, it's something that we've picked up as well with Turning Point, because actually traditionally the service wasn't designed initially for it to be addiction to prescription drugs, and that's something they've seen more and more. But what they're noticing that is that as the number of individuals are increasing, it's putting pressure on the addiction to the illicit substances. So it's trying to get that balance between the two, because actually around the addiction to prescription drugs, the work is about us working in partnership with the clinical commissioning groups and the GPs, because it's about the prevention rather than waiting for that addiction to happen. It's the education and awareness of what we can do early on, so that they're not having to go to a service like Turning Point. So yeah, we're a complete agreement, and I think it's something that we're wanting to take on as part of the strategy, but it was having that paper to waft to say we've got a strategy that's been endorsed.
No, I absolutely would 100% agree with the kind of re-education and making sure that patients never get to that point. But the reality is that there's going to be an increasing number of patients that are identified that are already there, so you're too late. And the re-education is not just about patients, it's also going to be about the GP populace that are over-reliant on painkillers for patients who have no other alternative because they live their life in pain and it's the only way to stop it.
So if I come in, I mean, you've got two opportunities, haven't you? There's priority one, which is the kind of education before you get into a dependency. Priority three, we have put in the bit about individual treatment services for prescription medicine. And again, I guess the whole point is where we talk about changing trends in drug usage. I suppose that was partly driven initially by thinking about novel psychoactive substances and your members and all that stuff. But clearly we need something, it would be useful probably from a scrutiny point of view to get a comment that says, actually, can you, this is something that you need to consider expressly. And I guess when we were talking about partnership working, the original focus was more thinking about how do we work with districts around the community safety agenda. Fairly silent in the strategy because we haven't outlined specific partners is the NHS. So coming back to the point about cancer screening, how do we reconnect again with the NHS more than we've done in the last 5 or 6 years? That would open up the opportunity to have a strategic discussion with the CCGs.
Sarah.
Thank you, Chair. I think what's just been said is very, very apposite, and then the priorities are good. It's joining up, looking at, and also perhaps changing what we do in light of what people do, because society moves on and people find different ways to get into trouble. Starts off as fun and ends up very badly. I've just was an observation to priority 4, reduce ill health and death as a result of alcohol and drug misuse. And on that particular page, Mike knows what's coming here, it doesn't actually mention alcohol at all. It just talks about drugs and particularly more to the opioids type things, which I don't know where we are with that. But yeah, I just thought it looked a bit odd like that. I know alcohol is important in this strategy, but it just wasn't mentioned there.
It's also feedback we've received via the consultation. It's not something I'd picked up until I read it in that, so we have amended it to include more around alcohol-related harm.
Right, thank you very much. Sorry, Terry.
Thank you, Chairman. Yes, I said I don't think anyone would deny the benefit of the strategy and having one. I suppose my question's on page 83, third paragraph in the second column, where it talks about identification of those that we can't reach. But there was nothing I sensed in the strategy about, embedding people in with the police, etc. So any Saturday night you'll pick up no end of people who clearly have substance misuse. So it's not difficult to find these people if we want to find them. Because there should be ways, so where we're embedding triage nurses and those sort of things, they must be able to provide the information that there may be an issue there. I appreciate you've got the agreement and all those sort of things, but there are areas, and I didn't sense from the strategy how we were going to do any of these things. And I suppose just from a point of view of timing, Mr. Chairman, it just strikes me that to see this report now without the benefit of the responses to the survey before it goes to Cabinet doesn't give your committee a chance to actually look at this, I think, as closely as it should do with the benefit of those responses. So there's a timing issue here, I think, which is, I would have thought your committee should have considered this once you'd had the benefit of the responses to the consultation. But on the other one, I just think it needs more beef on how it's going to be done. We can all have strategies to say this is what we want to achieve, but I didn't sense in this particular part there was any real, we want to get out there and find the information.
That's a valid comment. It's something that we'll take forward. I think we've started it off as it being that partnership working, because I think the issue currently is that we haven't been doing that talking, and so it's about establishing that in the first instance to get those things in, because the reason why I've put about early identification is because we've not got that link strong enough currently, and we need that to be embedded. So yeah, but it's a fair point, and it's something I can add in. Yeah, and it'll be part of the implementation plan. I guess it was just, are these the right priorities first before I drive forward what it is that how we're going to achieve what we achieve at this stage, and this is part of the consultation of these the priorities that you think fit for us in Leicestershire.
And then we have the timing problem. But Lee.
Yeah, it was just, I think, picking up on Terry's point, I think priority 5, the working with the emerging issues related to substance misuse. I think the work and feeding into the Health and Wellbeing Board, the Safe Communities Strategy Board and the Strategic Partnership Board, I think that will give that sort of feedback, and that also both ways. I think we can get that in, and I think we can start working on that, building it into the plan from this.
Now, we're finding this more and more, really. We had similar comments at the Scrutiny Commission the other week that some of the paperwork, it was going off back off to the Cabinet, and we only got it, if we did get it back at all, way after it had been approved and it was finished and done and dusted. So it's just timing. It's a timing issue, isn't it? Anything else? And clearly, this consultation ended on September the 2nd at midnight, and here we are. You're barely going through the results, aren't you? Oh no, of course that. No, I know that, but it's still the fact we don't get a chance to see the final report before it goes to Cabinet. That's all. And we had the same problem the other day. But yeah, I mean, obviously there are, and as Lee said, there are other organisations within it that will see it all. Any other comments on the misuse, etc.? In which case, thank you very much. The final point is that the next meeting we have is, before Christmas. I nearly said after. 13th of November. Look forward to seeing you. Thank you very much, everybody. I've seen the book somewhere. Isn't that there it is? Yeah. Well, I actually told Amanda I'd finish it by 4, and wow. To where? To Argos. Brilliant. Then there's the signing book somewhere as well. I'm not sure how many people sign up.